This is NCLEX audio, exam preparation content reviewed and approved by a licensed registered nurse before publication. Nothing here is medical advice or clinical guidance, and we have no affiliation with the NCSBN or any state board. Now let us get into it. Riverside General, medical surgical floor, 2:47 in the afternoon. Emergency medical services brought in Marcus Webb 30 minutes ago. 34 years old, high school science teacher. History of epilepsy, well controlled for 4 years on valproic acid. Today he had a generalized tonic-clonic seizure in the school parking lot. Witnessed onset, duration approximately 3 minutes. He is postictal now, confused, exhausted, answering questions slowly. The attending has ordered seizure precautions and continuous monitoring.
Okay, so I read the full paramedic report. Marcus, room 14, had a tonic-clonic in the parking lot. Went rigid first, then the jerking started. He was incontinent, lost consciousness, came around on his own before the paramedics loaded him. Now he is postictal, talking but foggy. Classic.
What type of seizure?
Tonic-clonic, generalized. Tonic phase first, that is the stiffening, the body going rigid. Then the clonic phase, the rhythmic bilateral contractions. Loss of consciousness. Paramedics confirmed it in the field.
What other types should you know coming onto this floor?
Absence, myoclonic, atonic, focal.
Tell me about absence.
Brief impairment of awareness, staring, no convulsions. Patient comes right back immediately, no postictal state. Childhood onset mostly, can persist. Lasts seconds.
If you watched one happen on this floor, what do you document?
I mean, if they come right back with no confusion, no injury, no postictal state, it was brief. I document that it happened, time it, move on. Clinically, there is not much to work with.
Try calling their name during one.
I would.
They do not respond.
Okay, but they come right.
Touch their shoulder.
Still no response?
It cannot be interrupted. From the outside, it looks like someone switched a person off for 15 seconds and switched them back on. No warning, no after effect. Which means if it happens during a med pass, during a meal, during a transfer, you might miss it completely.
And if you do miss it,
you document it as brief altered mental status and move on. That chart entry goes to the neurologist. They do not see absence seizures. They see brief altered mental status. Different diagnosis, different drug class, different outcome.
So the documentation has to name it as a seizure, not just describe the behavior.
Describe it precisely. Duration, whether it could be interrupted. Immediate and complete return to baseline. That is the chart entry that actually helps someone.
The tonic-clonic calls the code. Absence is the one nobody catches.
Write that down somewhere.
Okay, I'm going to go set up his room. I have the seizure precautions protocol.
Go ahead. Come back and tell me exactly what you did.
Jake was in room 14 for 6 minutes. He came back looking organized. That was the first sign.
All right, padded side rails up. Bed at its lowest position, done. Suction set up at the bedside, operational. Oxygen at the bedside, ready. Call light within his reach. And I placed a padded tongue blade at the head of the bed in case he seizes again.
What is the tongue blade for?
Airway protection. If he has another tonic-clonic and his jaw clamps, you slide it in between the molars. Prevent him from biting through his tongue. It is a standard precaution.
Is it?
It is in a lot of the older training materials. The logic holds. Protect the airway.
Walk me through the tongue. Anatomically, what is it attached to?
The floor of the mouth. It is fixed. It cannot go anywhere.
So can the tongue be swallowed?
No, but, okay, the tongue cannot be swallowed, but it can be bitten through. That is the actual risk. Lacerations, bleeding. The blade prevents the laceration.
How much force does a jaw generate during a tonic-clonic seizure?
1. The masseters are some of the strongest muscles in the body relative to their size. A lot of force.
So he clamps down on the tongue blade with that force.
The blade fractures. Or a tooth chips on the blade, and the fragment
goes where?
Into the airway. The thing I put there to protect him is the thing that obstructs him.
The tongue blade never goes in the room. Not at the bedside, not in the drawer. Take it out. The correct setup is what you already did. Padded rails, bed lowest, suction, oxygen, intravenous access. 5 things. That is the list. Nothing else.
So the rest of my setup was right.
The rest was right.
It seems so logical. The tongue blade.
I had a patient. Nurse before me left one in the room. Post-operative. He seized that night. Chipped a tooth on the blade. We scoped him to retrieve the fragment.
She said it like a fact. It had stopped being a story a long time ago.
He was fine. I wrote the incident report. Then I went room to room and pulled every tongue blade I could find on the floor.
What happened to the nurse?
She thought she was helping. That is always the hardest part. She was not careless. She thought she was helping.
The things that seem logical.
The tongue cannot be swallowed. That fear is not anatomy. It is reflex. And reflex is not a protocol.
His paramedic report says 2 of his students tried to hold his arms down during the seizure. They were trying to keep him from hitting the pavement.
What is wrong with that?
You do not restrain a seizing patient. The muscle contractions during a tonic-clonic, they are forceful. If you try to hold the limbs against the movement, you risk fractures, dislocated shoulders. You work with the seizure, not against it.
What do you do instead?
Clear the area, move anything he could hit. Get something soft under his head. Turn him to his side when you can. Lets secretions drain, keeps the airway open. Stay with him. And you time it.
How do you keep that straight when you are the one in the room and it is happening right now?
The way I think about it, every action answers a question. Turn to the side. Where does the airway go? Clear the area. What can hurt him? Protect the head. What is hitting hardest?
Maria waited.
Stay with him. Who calls for help if something changes? Time it. When does this stop being a seizure and start being an emergency? If I blank on the action, I ask the question. The question points me back.
Why do you time it?
5 minutes. If the seizure runs 5 minutes of continuous activity, or if seizures repeat without him coming back to baseline between them, that is status epilepticus. That changes the situation.
And the first drug.
Benzodiazepine. Lorazepam intravenously if there is access. Midazolam intramuscularly if there is not. Benzos first, every time.
Not phosphenotoin, not levetiracetam first.
Benzos first.
Marcus was 3 minutes. His students stayed with him. They did not leave.
He told them what to do. At the start of the school year, he walked them through what a seizure looks like and who to call. One of them dialed 911. You want me to check his glucose?
I want you to tell me why.
Because hypoglycemia can both cause a seizure and mimic the postictal state. If he is more confused than I would expect for where he should be in recovery, the first thing I rule out is a blood glucose problem. Finger stick first, before anything else.
Before anything else.
Jake went to room 14. Marcus was awake. Still slow, still watching the ceiling, but awake. He asked Jake about his students, whether they were okay. Jake told him they were the ones who called 911. Marcus did not say anything for a moment. Then he asked if anyone had fed the robot. Jake did not know what that meant. He pulled up a chair and asked. The fingerstick glucose returned normal. The valproic acid level came back 40 minutes later, subtherapeutic, as expected.
His left arm is weaker than his right. He noticed it himself. I am calling a stroke alert.
When did the weakness start?
It was in the paramedic report, immediately after the seizure ended.
And what did we say about Frank?
The timeline tells you what the snapshot cannot. But this is focal weakness, left arm. That maps to right hemisphere. That is exactly how an ischemic stroke presents.
How long after the seizure ended?
Immediately. The moment the seizure stopped, the arm was weak.
And if I called thrombolytics for a patient whose weakness started the exact moment his seizure stopped?
You would be giving a clot-dissolving drug to someone whose deficit might resolve on its own in 90 minutes. We did this already. Frank, different direction, same mistake. Snapshot versus timeline.
Name it.
Todd's paralysis. Postictal focal weakness. The cortex that drove the seizure is exhausted, temporarily. It looks like stroke. The timing tells you it is not. It resolves on its own, minutes to a few hours.
Your job, right now.
Serial neurochecks every 15 minutes. If it improves, Todd's, as expected. If it does not improve, worsens, or anything new appears that was not present immediately post-seizure, Then I escalate. I call the stroke alert then.
Then,
Not now. What if the paramedic report had said 8 minutes, still seizing when they arrive?
walk through it.
Status epilepticus protocol. Lorazepam intravenously, that is, first line. If no response, second line. Phosphenotoin, levetiracetam, or valproate intravenously, one of those. If still refractory, anesthetic agents, the intensive care unit. Intubation under consideration. And the clock started at minute 5. Not minute 8, minute 5. Let me say it back.
Go ahead.
Seizure types. Tonic-clonic is generalized. Tonic phase, then clonic phase, loss of consciousness, postictal confusion. Absence is also generalized. Brief staring, no postictal state, comes right back, cannot be interrupted. The one that gets missed on the chart.
Precautions.
Padded rails, bed lowest, suction, oxygen, intravenous access. 5 things. No tongue blade. Nothing goes in the mouth of a seizing patient. During a seizure, turn to side, protect the head, clear the area, do not restrain. Time it from onset.
Threshold.
5 minutes continuous, or repeated seizures without return to baseline. That is status epilepticus. Benzos first. Lorazepam intravenously, midazolam intramuscularly if no access. Then second line if benzos fail.
Postictal.
Fingerstick glucose first, because hypoglycemia both causes seizures and extends the confusion. Then serial neurological checks. Todd's paralysis if there is postictal focal weakness, transient, trending toward resolution. Escalate if the trend reverses or new symptoms appear.
Triggers.
Medication noncompliance is the biggest one. And the patients who stop because they feel fine, the medication is why they feel fine. Sleep deprivation, fever, alcohol, electrolyte problems, hypoglycemia.
Pick one from that list. Give me the mechanism.
Fever. A febrile illness lowers the seizure threshold. The brain becomes more electrically excitable as temperature rises, which is why a child with febrile seizure history runs higher risk during any illness with high temperature. The seizure is not caused by the infection. The fever is the trigger. Bring the fever down, you remove the trigger.
And why does that matter for your epilepsy patient on valproic acid?
Because fever plus subtherapeutic drug level is 2 triggers at once. Marcus ran out of medication and, did he have a fever?
A febrile on admission.
1 trigger was enough.
That is a shift. Go chart.
Marcus Webb was discharged 3 days later. His valproic acid prescription was adjusted. A social worker connected him with a patient assistance program before he left. His left arm weakness resolved completely within 2 hours of admission. His students sent a card to the nurse's station. It said, in 12 different handwriting styles across 1 sheet of notebook paper. He told us what to do. We did it. If you want to test how well today stuck, the audio quiz at NCLEX-RN covers everything from this episode. Seizure types, precaution setup, status epilepticus thresholds, postictal assessment. Take it once, come back in 3 days, and take it again. The second time is the one that matters. Subscribe so the next case is waiting when your commute starts. You are building something real, 1 shift at a time. You have got this.